Oh, thanks, Jamie, for an excellent talk. I think we have Jamie. Oh, yeah. Hi, Jamie.
Hi, Trudy. Hi. It's quite funny listening to your own talk.
Yeah, I bet it is. Thanks for
Yeah.
that. That was brilliant. And I contacted you a few years ago when we set up the
Spotted
St
my
George's
typos.
postnatal. When we set up the postnatal hypertension service at St George's, and we pretty much based it on your trials. But there's been more development since, and that toolkit that you've referred to will help that service even more. Because what's difficult, I think, as a clinician practicing in that area, is trying to predict what's going to happen with the blood pressure next. So when you put that next appointment, what do you anticipate you're going to be doing with the blood pressure medication in regards to titrating up or down? When are the key points that we need to be involved? And then we're further constrained, of course, by the NICE guidelines. So when do you think the NICE guidelines will actually reflect your recommendations? Do you think that will be reviewed at any
That's
stage?
a really good question. Obviously, both Lucy and Basky were involved in those guidelines. They were both big proponents of home BP monitoring, and they were both on the papers. And involved in the trials for POP, SNAP2, and many of the trials. Lucy's the PI on the antenatal panda study. Giant panda. So I think they're just waiting for a tiny bit more traction. The papers are out there. America is taking it up. So I think when it's next due for review, it's probably when it will come into the NICE guidelines. Certainly ESC have sort of taken it up, and generally NICE tend to sort of follow shortly after.
Okay, great. So we should see a change that will obviously affect our clinical practice going forward, in the nearer future, perhaps. We've got a question in the chat from Rochelle. I note there's now a clear distinction between ethnicity and the most effective medications to control BP. What makes one drug more effective than another when it comes to ethnicity?
Yeah, so that's a really good question. Sorry if there's a lot of background noise. I'm actually at the British and Irish Hypertensive Society up in Manchester, and they've just all come out with a special lecture for lunch. So it sounds like an elephant stampede going behind me.
Yeah.
So can you hear me okay?
Yes, yep.
Okay, so yeah, essentially that question, the answer to that question is thought to be, like in thought in inverting commas, because we don't fully know, and that's been evident throughout the talks here actually. There's been a lot of data presented on these ethnic disparities, but traditionally it's thought it's due to the fact that African and Caribbean born people have low renin, and low renin hypertension, it doesn't tend to respond to drugs that block the renin-angiotensin aldosterone system. So the mechanisms of that aren't fully understood. There's people doing research on that very complex cascade. You might remember studying in a book at one time where there's, arrows going everywhere from renin converting angiotensinogen to angiotensin 1 to 2. It goes all the way up to 7 now. I didn't even know that. When I was in med school, it only went to 3. And there's these other drugs into going in, like neprilysin, which is a drug we're now blocking in half. So it's a super complex cascade. We don't really understand. But the sort of consistent thing is that you have low renin, and certainly trials have shown they don't respond as well to these drugs. So that's why NICE, the European and American guys say calcium channel blockers, and that might be one of the reasons why the Americans actually went for calcium channel blockers there first, like because they have a much bigger, black born population than we do.
Yeah.
Albeit, Georgia's, you've got a little bit more than some parts of London, Manchester, there are pockets around the UK. It's fairly low where I work in Oxford and Reading's more Asian ethnicity, and traditionally trials are just not taking account for sex and race differences. The historical trials weren't done well. They were middle class men in America, white middle class people, like all the Framingham studies, all the ISIS trials in Oxford that underpin the drugs we use in cardiology they weren't done well. Trials are recognizing that, and funders, and trials now are hopefully going to be able to answer these a little bit more in more detail as to why one drug favors another. we certainly know that people who are African and Caribbean have stiffer aortas, for example. You know, their pulse width velocity when you measure the speed of the blood through the aorta is higher, and that might be a mechanism why they respond to calcium channel blockers, because that's what's driving their hypertension more, and they're in organ damage. They have higher rates of kidney disease, higher rates of stroke, higher rates of HFpEF later in life. So yeah, so we definitely need to do some more work on figure out which drugs are best for this huge cohort of women. But at the moment, it's calcium channel blocker.
Yeah,
so hopefully that answers that.
Yeah, and for that links really nicely with the second question, actually, is around, does that same physiology in renin apply to Asian Indian women?
Again, there's a real lack of trial data around that, but no, not a lot of sensitive data, then there's convincing data that there is a benefit of ACE inhibitors, but the small trials that have been done, Asian women still favour ACE inhibitors and ARBs first line. And in my own experience, they tend to respond well. But I mean, what you could do, obviously it's all cost, and is check your renin level if you're seeing people. But obviously, you know, that takes 10 days to come back. But, you know, it's useful for if you're seeing someone like down the line, if they remain hypertensive, you know, beyond the period you're looking after them, you know, obviously midwife care will transition usually, you know, at the 6 to 8 week point. But if at that point, you know, still requiring drugs, it's often something we'll do in the general hypertension clinic to try and guide which drugs we should be using.
Right. Okay. Yeah, that's useful information. Well, thanks so much, Jamie. It was a fantastic talk, and yeah, really appreciate you.
Thank you. There's
one more?
There's one from Kalichi who says she's curious to know about the statistical numbers of Afro-Caribbean women that participated in the study and concerned the data might be racial. Which study is that, Kalichi? Are you talking about the POP trial, our own trial? Are you able to just put that in the chat box? If so, in that trial, yeah, 80% were white Caucasian. There were 20% of the BAME, of which half were African, so 10% were African or Caribbean born, and the others were either Hispanic or Southeast Asian. So not huge, but that's the national demographics, not the national, sorry, the regional demographics within Oxfordshire. So there's not a lot we could do as a single centre, but that's why SNAP's being, you know, performed SNAP 2 across, you know, many centres, and they purposely selected sites to try and recruit, you know, higher numbers of Afro-Caribbean women. So they picked George's as a site that's due to come on soon. You know, they've got Manchester, and a few other sites in London and Birmingham to try and address these and increase the ethnic variations. But, you know, there is no trials I showed in the US that showed the benefits of BP monitoring in the US in terms of improving adherence, where it's a massive problem, as I say. Only 1 in 10 women in the US get a BP monitoring, a BP measure done after they get discharged. So it's a low bar to improve in the US.
Great. Was that it for questions?
Oh, sorry. Oh, I just see she came back. It was the low renin level study.
Okay.
Yeah, so that actual study was a study based in Africa, and it had about 1,000 people in it from a variety of countries like Kenya, Tanzania, Ethiopia. I'd have to read the paper in more detail, but it was a reasonably sizable study about that. But there are other papers that actually show that the levels aren't hugely different. So, like I say, it's an area we need to understand more. The one thing we do know is that the outcomes are worse in terms of renal and organ damage in the heart, stroke, dementia, and that their aortas are stiffer. And that might be one explanation for why calcium channel blockers are better. And in my own experience, calcium channel blockers are definitely better. If you use ACE inhibitors alone, they just do not work. We tried it in POP because we were trying to follow NICE. And use a lot of enalapril, but we always had to use high doses of calcium channel blocker in the black women that we had in that study, and the ACE inhibitors were just a second line, really.
Okay, thanks so much, Jamie. Really appreciate it. It was an excellent talk, and thanks for coming in from the conference.
No problem at all. No problem at all. Enjoy the rest of your day.
Enjoy lunch. Yeah. Thanks a lot.
Bye-bye.
Bye.